Okay. Okay. I think we're all set here. All right. So I don't know if you've been scrolling down our syllabus online, but I've been graying out stuff that we've completed. So obviously we're to here. And if you look, there's not much of the semester left. So light at the end of the tunnel. We're almost there. Don't let up the steam. Keep the pressure on. Our lecture exam, most of it is, and when we get a week away from it, I'll send you a breakdown like I've done before, but most of it is going to be chapter 7, which is blood physiology, and then chapter 8, which is all that cardio stuff. And then I said here, first part of chapter 11, which is what we're in right now. And I'll decide what that cutoff point is, but I haven't decided yet. So as we get more through it, I'll decide. Okay. And we have the kidney physiology lab this week, and of course, lab quiz, the official quiz format. But then next week, there's a case study, and I'll hand that out to you when you get to lab. Okay. Yes. It's the old textbook that I used to use, and I haven't changed it to the Fox textbook. Okay. But it's, and we'll double check that. Let's double check that. It's chapter 11. I'll go back to the wiki textbook right here, and we'll look. Okay. Okay, chapter 11, respiratory system. Where are we here? Right there. So in our textbook that we're using now, it is chapter 11. I simply forgot to update the PowerPoint chapter, so don't get confused by that. If it's respiratory material, that's the respiratory chapter. So hopefully, at the end of the semester, I'll correct all the chapter numbers. Okay, any questions about that? Because I think this is where we left off. Pretty sure. And that would have been where we left off on Wednesday, because after the quiz, I just decided to just let you go. Now, hold on. It's trying to record me, and all that text on the slide is very distracting. So turn that off. Here we go. So this is where we left off on Wednesday and then Friday. The reason I'm not handing back the lecture quizzes to you today in the folder is there's still one person who has to do a makeup. So I'm going to wait till they do that makeup, which is Wednesday. And that means Friday, I'll pass them back in that folder. I'll have it up here for you. Okay. I was pretty happy with the quiz results. I think you guys did really well with that. All right. Okay. So decided not to show this video. You can look at it on your own, but I talked about, to recap, because it seems like it's been forever since we actually had a lecture. This is an alveolar sac, one of many, many millions of sacs that you have in your lungs. The wall, the membrane right here, here's a little cell nucleus, here's a little cell nucleus. It's a 1 cell layer thick, very thin to allow gas exchange. If it were thick, gas exchange would be very difficult. That's the pro, good gas exchange. The con, that thin membrane is very subject to damage from inflammation, viral attack, all that stuff, COVID, all kinds of things like that. So I think I left off talking about how vulnerable the sacs are because they're so thin, and trying to apply it to common respiratory things. And we'll talk about some common respiratory disorders. Anything that causes chronic inflammation or irritation of the airway here, the alveolar sac, our body's response to inflammation is because of histamine, swelling, thickening. Fluid often accumulates in an area that's inflamed. So fluid can accumulate in your sacs, and that actually dilutes the surfactant. So we talked about surfactant yet or no? We'll talk about it in the next slide. All right. Okay, so let's move on to the next slide where I can explain that. So type 1 alveolar cells make up the cell wall. Okay, that's that thin 1 layer membrane. So let's flip this around. Make sure our pen's working today. Nope. There we go. Change the color of the pen. Okay, makes up cell wall, makes up the alveolar sac walls. Very thin. Okay, that's the thing about those sacs that makes them very vulnerable. Now, type 2 alveolar cells, let me move this thing out of the way. Okay, oops, this is wrong. It's type 2. So type 2 is pointing to this cell right here. Type 1, this is correct. That's the cell wall. Now, during fetal development, eventually these type 2 alveolar cells will become functional and they'll start doing what they do, which is produce surfactant. All right. Now, before I explain what surfactant is, dry membranes aren't best for gas exchange. They're not. All right. Slightly moist membranes facilitate gas exchange. So your type 1 cells have sodium and chloride ion channels that help regulate a little bit of water secretion onto that membrane. All right. Because wherever salts go, water follows. So the inner lining of the sac has a very thin layer of water, very thin. Okay. Just enough to moisten the membrane to allow gas exchange to occur. Now, I don't know if you've ever watched Discovery Channel, National Geographic, ever seen one of those lizards that can run across water, all right, or even just tiny insects that can. Water, due to hydrogen bonding, has a strong surface tension. Now, that's good if you're a stick insect walking across water, but what happens in your alveolar sacs is when air comes in, they expand. When you exhale, they shrink, expand, shrink, just like your lungs. When they shrink during exhalation, that water lining the sac makes them want to stick together. Have you ever been in micro lab where you prepared some slides or something? I don't know if you guys do that. And sometimes you grab them out of the box or the dispenser, and sometimes 2 slides are stuck together because there was a drop of water or something between them, and you try and separate them. It's almost impossible. You're like, forget it, I'll just grab another slide, because that surface tension with the water is holding those slides stuck together. That's what will happen to your alveolar sacs with that water, just like the microscope slides. Once they touch, that's it. They don't want to expand again when you inhale. Okay. Surfactant reduces that surface tension. So surfactant decreases surface tension of the film of water, allowing the alveoli to not stick together. I'll say stick together or collapse, parentheses, collapse, during exhalation. That's important, that surfactant, all right? If you didn't have that surfactant, every time you exhaled, those sacs would want to stick together or collapse. And if many alveolar sacs collapse in unison during your exhalation, it can collapse part or all of your lung. It can lead to a collapsed lung. All right, so I'm leading to something here. I don't know, I have what else on this slide. Yeah, so I was defining surfactant here. I forgot I had that here. So every time you exhale, the alveolar sac gets smaller and is at risk of collapsing when the walls touch each other. Surfactant prevents that from happening. And that surfactant is secreted at a certain around month 8 of gestation. The little fetus is making it, its lungs are making it. Babies are sometimes born prematurely, aren't they? For one reason or another. And when they come out, sometimes they're not fully cooked. Lots of organ systems aren't fully functional yet. The lungs are the number one thing. So as future nurses, if you are assisting in childbirth and the baby's premature, the number one thing you're going to check is that baby breathing? All right. Because the lack of surfactant or sufficient surfactant, because they were born before those type 2 cells were making surfactant, that baby's going to need ventilatory assistance. They might have to go into the NIC unit, into a specialized chamber where they provide them with high oxygen and a synthetic surfactant that they can breathe in. They might have to ventilate or assist that baby. Okay. Has anyone ever known someone who's had a premature baby that had to go into the neonatal intensive care unit and get ventilatory assistance because the lungs weren't mature yet? It's very common, so common. So you'll see it. So the application, I was just talking to a hospitalist who oversees doctors at the hospital in Charleston, and he was talking about atelectasis. All right. But he was talking about people recovering from surgery and atelectasis. But here's a couple types of atelectasis, and I'll keep repeating it because when I saw this, because I don't think they mentioned it in the textbook, but this is what it's called. It's basically something that leads to a collapsed lung, atelectasis. Now, a couple of categories, non-obstructive and obstructive. So non-obstructive is there's no foreign body in the airway. It's usually a result of too little surfactant present or produced. And the alveolar sacs collapse. Okay, so that's what they're showing here is during exhalation, when these sacs get smaller in size, without enough surfactant, that water, that thin layer of water and the surface tensions it brings makes those sacs collapse. And so if all the lungs are lacking enough surfactant, you risk complete collapse of the lungs. And so collapsed lungs, all right? What they do for these babies is they provide the synthetic surfactant and respiratory assistance until their little lungs, their sacs can start producing enough surfactant on their own, and they can prove the baby's ventilating fine, and then they're good, okay? Now, you can have a collapsed lung due to obstructive atelectasis, and that involves a foreign body in the airway. That prevents air entry into part of the lungs. When I say part of the lungs, because when I first introduced this chapter, I talked about branching off the trachea, our primary bronchi, and then after the primary, secondary, and after the secondary, there's tertiary. So depending on where that obstruction went, everything downstream of the obstruction is not getting air, and the sacs collapse because they're not filled with air, and that's a collapsed lung. Now, part of your CPR training, which you have to be American Heart Association basic life support CPR trained to once you get accepted to the nursing program. And part of that training should include the Heimlich maneuver, which can remove, hopefully, a foreign body if it's in the upper airway. Once it's down into secondary, tertiary bronchi, that's going to be a surgical fix. You're not going to pump that back up. But if it's primary bronchi, certainly the trachea, you can probably compress to get that foreign body out. But basically, everything downstream is not going to get air, and those alveolar sacs collapse, and then the lungs collapse. So that's a collapsed lung. All right. Okay. And there's other ways to get a collapsed lung. This is just one. Not enough surfactant, foreign body, someone chokes on something. But then there's other things. And we'll talk about that. So atelectasis. Go into the nursing program knowing how to pronounce that. They'll be like, oh, dang, look at the vocab on this student, because it's kind of higher level vocab. Okay, but these are things you see with a premature baby, and this is the risk with choking. Okay, so continuing with respiratory problems in general. Infant respiratory distress syndrome, or IRDS. I don't know if I have it written out. I think I do. So getting back to the surfactant, 28 weeks, 7 to 8 months, all right? That's when their little lungs are producing surfactant. If they're born before that, they don't have enough surfactant. When they take their first breath, great. But then when they exhale and try and inhale again, some of those sacs will have collapsed. And when they're trying to breathe in and the sacs are going, can't do it, can't open, collapsed, like 2 microscope slides stuck together. And then the baby can't breathe. So non-obstructive atelectasis. So treat with a synthetic surfactant delivered into the baby's lungs, mechanical ventilator, in a neonatal intensive care unit until the lungs are mature enough to do it on their own. And this is kind of on the daily. That's how common it is. Now, adults, anything that causes chronic inflammation of your airways can lead to this problem, atelectasis. So adult, I think acute respiratory stress, I think adult acute respiratory distress syndrome. This is the problem with COVID, or any kind of chronic lung inflammation disorder, like COPD, all right? or chronic asthma that's not being treated very well, or chronic bronchitis that's not being treated very well. Long-term smoking or vaping causes chronic inflammation of your airways. So due to inflammation, it could be from an infection. All right, that's possible. Any kind of, somebody put here, chronic inflammation. That's the big thing of the airways. From whatever reason, all right, inflammation, another M, okay, results in fluid accumulating at that site. Things that are inflamed, they swell, equals swelling and fluid accumulation. Okay, that's anything that's chronically inflamed, but if it's happening in your airways, it's happening there. So the alveolar sacs can swell with inflammation. They can fill with some inflammatory fluid, which is basically serum leaking into them. The fluid present dilutes the surfactant that's there. And so with the surfactant being diluted, it can't do its job. So there's a risk for those alveolar sacs to collapse. All right. Plus they thicken. So it means they're not going to function very well. And it could lead to, well, this is in the way. Let me move it. Okay. Higher surface tension, the alveolar sacs want to collapse, and then you can lead to lung collapse left untreated. Now, many things can cause ARDS, but certainly COVID, all right? So I've written over it, said COVID causes ARDS. And you can click here if you want to read more about it. You're probably very educated about, I hope you are, about COVID-19, what we've been dealing with for the past 2 years, turned the whole world upside down. Okay, have you ever heard of the long COVID? Some people get it, they get over it because they're healthy. They got no other underlying problems like diabetes, heart disease, who knows what, okay, chronic hypertension. And they get over it. They're sick for a little bit, feel sick as a dog, but then they're back, right, within a couple of weeks. Not everyone's that fortunate. Some people's immune system is not that great. Maybe they're immunocompromised, maybe they have some sort of disorder, any other second underlying condition like high blood pressure, cardiovascular disease, diabetes, a whole long list makes them more vulnerable because their immune system is not quite up to the task. And so their body fights it for a longer time. And you have chronic inflammation and you can damage those alveolar sacs. The immediate thing is swelling and inflammation with fluid collection, dilute surfactant. But long-term, the sacs become permanently damaged. If you have a tissue in your body that's chronically inflamed, people like people with eczema or other things like that, people who have IBD, inflammatory bowel disease, or Crohn's disease, or anything else like that, where a tissue is constantly being inflamed, what the body does that over time is it lays down scar tissue. That's kind of its permanent fix. Scar tissue will never behave like normal tissue ever again. Once scar tissue is formed, it's permanent damage in your lungs. If you have chronic inflammation from smoking, vaping, COVID, the list goes on, asthma, bronchitis, COPD, the huge list. Over time, if you can't get that under control, the alveolar sacs will form scar tissue and they'll never behave the same. Scar tissue is not flexible. Alveolar sacs are supposed to go inhale, exhale, inhale, exhale. Scar tissue doesn't have that flexibility. That's permanent damage, right? So I know I'm kind of going off script, but I'm trying to describe a process that can happen. So I think I've got some information on COVID here. Yeah, the sacs are very thin. Good gas exchange, but they're very vulnerable to damage. Chronic inflammation will destroy that thin membrane, okay? So any kind of chronic inflammation leads to thickening of the walls. Gas exchange is difficult across thick surfaces. If it becomes scar tissue, it becomes virtually impossible for gas exchange to happen, all right? So people with ARDS will have low oxygen levels. In fact, anything lower than 95% oxygen saturation, people who had COVID, they watch their pulse oximeter, put it on the finger, and it's able to monitor oxygen saturation of the blood. If it drops below 98%, that's when the person is put on a ventilator. I'll get to that in a second. The inflammation causes fluid buildup that dilutes surfactant, decreases gas exchange. Now, fluid trapped in inflamed lungs. The lungs are a warm, now moist environment. Bacteria love to thrive in that environment. And then you can have secondary things that happen, like pneumonia. So all these things could happen to someone who got COVID, all right? Okay, And there is a good YouTube video, which I think I'm explaining it, but if you want to look into it more, this kind of interests you, yes. When people get put on a ventilator, at least when COVID started, okay, they've become a little smarter now. A ventilator gives you air, high oxygen saturation under high pressure because you've got sacs that are collapsed or not functioning very well. So you really want to get that air in there. Come to find out that being put on a ventilator with forced air at that pressure that they were using before caused more damage. Now they're doing lower pressure ventilation on these COVID patients. And the people feel like they're not getting enough air, but they are. It's just being delivered under low pressure. And they actually sedate these patients because they feel like they're not getting enough air. So they start to struggle. Is anyone familiar with any of this? Have you read up on any of this? I've been reading journals and stuff like that. Well, anyway, they do lower pressure air ventilation now, and they'll sedate the patients so they're not fighting, trying to pull out the tube and stuff like that. All right. So we learn as we go along. We're treating COVID better. But there's all these complications, these compounding factors. That's what makes COVID so scary. So radiographs, really good for looking at lung fields. Radiographs, things that are dense come out as white like bone. All right. So you can see the ribs and everything like that, and the humerus and everything. And starting to see this is part of the heart right here. Okay. But so the heart would be up here. No, it is. That's only upper part of the lungs, I guess. But anyway, you can see the thoracic vertebrae with the discs in between. The air spaces are nice and dark. Air spaces should be dark in the lungs. If there's any amount of grayish or little flecks of white, that's a problem. That could be fluid. That could be scar tissue. It could be little tumors. Who knows what? All right. So this is a normal lung field. Now, here's someone with pneumonia, which is basically a bacterial infection in the lungs, which could include inflammation and fluid along with bacteria. And all this is abnormal. Okay. That would not be a good x-ray. Now, COVID. Now, obviously, they've actually intubated this person. Now, I don't know what all these lines are, and that's some sort of metal clip holding something together. That's not inside the body, that's exterior. But yeah, it looks very similar to pneumonia. It's just all fields of gray and white. Inflammation, fluid, and who knows, maybe a secondary bacterial infection. But imagine trying to breathe with all that gunk in your alveolar sacs. You're not going to get good gas exchange at all. Now, this is interesting. I pulled up this because I try and stay current. So here's someone who's been vaccinated that still got COVID. That can happen. It's called breakthrough infections. It does happen. Vaccines aren't 100%, but they're pretty damn good to nothing, but they're not 100%. And so this person has a lung field that there's some dark air spaces, but you can still see some stuff in there, versus someone who's unvaccinated COVID positive. There's a lot more diffuse fluid and inflammation in that lung. These lungs are much worse shape than these lungs. All right. So, okay. Now I'm off kind of the applied aspect of surfactant and collapsed lung and inflammation in the lung and long-term inflammation in the lung. Let's just talk about mechanics of breathing. This is true physiology. Okay, before I was kind of getting more into the nursing field. The membranes of your lungs, you learned them in anatomy. There's two membranes. There's a membrane that actually covers the lung itself. Okay, so I made it in dark blue. And since it's covering the organ of the lungs, organ means viscera, the membrane's called the visceral pleura. All right, the pleural refers to lungs. So that's covering the lungs themselves. Then the other membrane is called the parietal pleura, and I colored it green. That is basically surrounding the cavity that contains the lungs, or the pleural cavities. That parietal pleura is stuck to your thoracic wall with water through surface tension. It's literally stuck to it like the glass slides. All right. So when you expand your lungs, you take in air and the lungs expand. What's happening is the expansion of the lungs is due to muscle activity. Your diaphragm is the main respiratory muscle. When it contracts, it bows down and it makes the thoracic cage expand. And then your intercostal muscles, scalenes muscles, and other muscles, which I'm not going to go there, but they will increase the thoracic cage size. Since the parietal pleura is stuck to the thoracic cage, it expands with it because it's stuck like two slides. And that will make the lung volume expand when that happens because that parietal pleura is stuck there. So those membranes are pretty important. Okay, The intrapleural space is basically the light blue in between the green and the blue line. That space is just a potential space. There's never supposed to be air in that space. There is a little bit of fluid in that space, serous fluid. It's a lubricant because when your lungs expand, contract, if those membranes, parietal, visceral, pleural, were to rub against each other, the friction and the heat would destroy the two membranes. And any moving part has got to have a lubricant for you, just like why you put oil in your car. The pistons are pumping, they're not lubricated, they're going to seize up because of friction. Your lungs are the same way, like pistons of a car, except it's doing this. And you don't want the membranes directly rubbing on each other. This space, like I said, should never have air in it. If it ever has air in it, you're going to have a collapsed lung due to something different, not surfactant, not chronic inflammation, but just air somehow gets into the space where it shouldn't be. You're going to see a pneumothorax, pretty common, very common. So the reason of me explaining this anatomy review of these two membranes is to explain what a pneumothorax is. Has anyone ever here experienced a pneumothorax? Got an injury or something like that? My brother got one from playing hockey and he got checked, which means some big burly person ran into him, actually cracked his rib, and the rib poked into his lungs and actually ruptured this parietal pleura. And it was a minor little break and everything like that. And it was going to heal on its own, but he ended up with a collapsed lung and had to be watched. And he had to have his basically his lungs tapped to remove the air that built up. I'm going to explain this in a second. But basically, because of the break in the green membrane, parietal pleura, air rushed in. Okay. All right. So there's going to be a lot of physics coming, but don't be afraid. Because the body, especially lungs, works on principles of physics. So air moves from high to low pressure. It's just diffusion. Things move from where they're in high concentration to where they're in low concentration, right? Passive transport. Movement of oxygen and CO2 is based on where is the pressure of those gases highest, where is the pressure lowest across the membrane. If it's high on one side of a membrane and low on the other side, guess where it goes? High, low. That's it. It's as simple as that. That's the mechanics of it. It is based on physics, but atmospheric air pressure around you is constant. We in the PD are pretty much near sea level, so the air pressure around us is 760 milligrams of mercury or torr. So the air pressure around us is constant. So how do you get a pressure gradient across membranes to make air move from point A to point B? Your respiratory muscles create a pressure gradient, so that's different from atmospheric. And that's what allows gas exchange to occur, your respiratory muscles. Okay, so lung air pressure depends on what is the volume of your thoracic cavity. And the volume of your thoracic cavity is going to determine the pressure of the air inside your lungs. So air pressure in a closed chamber changes with the volume of that chamber. So Boyle's law is the law of physics that states in a closed chamber, like your respiratory system, if your mouth and airways are closed, as the volume of the chamber increases, and I'm going to get to it in a second, your respiratory muscles do that. When your diaphragm contracts, it moves down, and your intercostal muscles move, it'll expand them outward, diaphragm moves it downward, and the thoracic cage increases in volume. The parietal pleura is stuck to it, so it expands in volume. That means the size of the inside of your lungs, the volume of your lungs, changes with it and gets bigger. So as volume of the closed chamber goes up, here's Boyle's law. Air pressure within that chamber goes down. Okay. So the bigger the volume of the chamber, the lower the air pressure in it. Imagine a chamber with air molecules in it, little O2s. Okay. If that chamber gets bigger, now there's less pressure between those air molecules. Okay, imagine walking into an elevator and there's just one or two people and it's a good size elevator. The social pressure is pretty low because it's just a few people, but you walk into an elevator, there's 14, 20 people in there. All of a sudden the social pressure, oh God, I'm in with all these people. I've got high pressure, very pressure situation, right? Think of it like that. The chamber gets bigger, the pressure of the air within it goes down. As that air chamber gets smaller, the oxygen molecules now more crowded, there's higher pressure. So as the volume of the closed chamber goes down, the air pressure within goes up. Now, I forgot to bring a syringe with me, but you know what a syringe looks like. Okay, so I've got a syringe. There's no needle or anything. It's an open bevel at the end of it. And it's got a little plunger tied to a plastic handle. You pull on the handle, the plunger goes up, and you suck in some air into that syringe, right? Like a big syringe. Now, if you put your finger or tape up tightly the opening to that syringe and then start pressing on the plunger, and the plunger goes in. If you've ever done this, maybe I'll bring one to the lab and you can see, or maybe on Friday I'll bring one. All of a sudden, as the chamber is getting smaller and the air within it has less volume, you get a lot of resistance on that syringe, don't you? Okay, you get to the point where you can't press it anymore. I have a funny story to tell you about Dr. Pryor. I have all these good stories. So when I was a licensed vet tech, we would do heartworm clinics and dogs would come in and I was running them. And basically he would hold off the vein. I drop some blood in a syringe and he would then be responsible for putting it into like a EDTA tube for heartworm testing later. It has that rubber stopper. And, you know, he didn't have any training. And I just said, stick the needle into the tube and put the blood into the tube and it'd be fine. And he put it in, but he didn't put it in deep enough. He didn't clear the rubber stopper. It's supposed to go all the way through. And so basically he occluded or closed the end of that needle. So the fluid had nowhere to go. And as he pressed and pressed and pressed, the fluid pressure began to increase until eventually it just blew up in his face. All right. Blood spattered everywhere. He turned to me with a look of horror. You know, so air and fluid and the trapped space, as the space gets smaller, the pressure within gets bigger and bigger and bigger. And well, he never did that again, but it was Boyle's law in action. I didn't say that to him. That was not the right time not to say something like that to him. But anyway, here's what's happening in your lungs. So as your lungs get bigger with the contraction of the diaphragm, so when it contracts, it moves down and the lungs get bigger because the thoracic cage got bigger. That's the order. Thoracic cage gets bigger. That makes the lungs get bigger because they're stuck to the thoracic cage wall. So when the diaphragm contracts, thoracic volume increases. That makes the chamber bigger. The lung volume increases because the parietal pleural stuck to that thoracic cage. And the intrapulmonary within lungs, the pressure of air within the lungs goes down. There's more space, less pressure. The opposite, when the diaphragm contracts, passively, it bounces back upwards. That makes the thoracic cage get smaller, and then that makes the lung volume get smaller. Then that makes the that makes the pressure go up. So thoracic cage relaxes, that decreases the thoracic cage volume. And since the lungs are stuck to it, that decreases their volume. Now we've got a smaller space, incredibly high, well, not incredibly high, but high enough, increased air pressure. That is the pressure differential. If atmospheric air pressure is constant, when your diaphragm contracts, thoracic and lung volume go up, and the pressure within the lungs drops, it drops to about 3 millimeters of mercury below atmospheric. So now in the lungs, air pressure is a little lower. Outside the lung, it's a little higher. Where does it go? From atmosphere into your lungs. When your diaphragm relaxes and moves up, makes the thoracic and lung volume smaller. Now the air pressure in your lungs, intrapulmonary pressure, is about 3 millimeters of mercury higher than atmosphere. And so it goes from high inside your lungs out. That's it, Boyle's law. All right. You must establish a pressure differential. Your respiratory muscles do it. And that's what causes the gas exchange to occur. Same principle is going to happen at your tissues. Now we're talking arterial blood will have a higher oxygen pressure than venous blood. And then tissues, it'll be where is the pressure of the gas higher? Where is it lower? You know automatically where it's going. But it's all based on pressure of gas differential. So I know physics is hella boring, so let's move on. This is what have been the plunger experiment. If you pull the plunger up and make more volume in the chamber, the air pressure is low. Pressure here is 100 millimeters of mercury. As you press the plunger in, now the air is trapped in a more confined space and the pressure here shows it doubles. All right. And so this is just to show you what your diaphragm is doing, the main respiratory muscle. When it contracts, it moves down, and the thoracic cage, this is showing some ribs, thoracic vertebrae, and the sternum right here. it gets bigger. Lung volume gets bigger, air pressure within it drops. When you diaphragm relaxes and moves up, thoracic cage volume gets smaller, makes lung volume smaller, but now the pressure is high because you got air trapped in a confined space. All right, that wasn't too bad. That was your first law of physics. You survived it okay? Good, I hope so. Oop. Okay, so this is just repeat of the same thing. And again, I've included just for your own, if you want to look at it, because sometimes the video does a good job, showing you when the diaphragm contracts versus when it relaxes. So when it contracts, it's down here. And when it relaxes, it's up here. And the black airspace on this radiograph is showing you what's happening to the lung volume during both of those events. You now know if the lung volume is big, it goes down here, pressure is low. The lung volume small up here, it's high. Okay. So a little bit of vocab. Intrapulmonary pressure equals the pressure, the air pressure, let's say, in the lungs. Now, when you inhale, because the diaphragm contracts, it drops the pressure below atmosphere. And when the diaphragm relaxes, that's when you exhale, the lung volume gets smaller. The pressure is a little bit above atmospheric. All right. If there's no pressure gradient, there is no gas exchange, period. It's just like if the concentration of solutes are the same on either side of a membrane, like salt, does water go anywhere? No, it needs a differential. Now, pressure inside the two membranes. Between two E's, the visceral and parietal pleural. Is always negative. Okay, there should never be air in that space. If you have air within that space, especially if the air keeps filling that space, you're going to have a collapsed lung. All right, so notice it's always negative. When you inhale, it's -6. When you exhale, it's -3. It's always negative. If it becomes positive, you're looking at a pneumothorax. So the question is, how does air get into that space? Well, in my brother's example, his broken rib punctured the parietal pleural and actually from within, it allows some air to escape. It must have actually punctured the visceral pleural too. That makes sense. But somehow air gets into that space. So there's a traumatic pneumothorax and then there's a non-traumatic pneumothorax. And I'll try and explain the difference between the two. All right, so it always should be negative. I think I made that point clear. Okay, so in pneumothorax, you're gonna see it. I used to see it in animals that got hit by cars because of broken ribs and whatnot. But air enters the intrapleural space. The pressure should always be 0. If it becomes positive, here's what happens. If air gets into that, and here's the parietal pleural, here's the visceral pleural, and the space in between. If air gets into that space swells. Now the parietal pleural is right up against ribs. It's not going to give. It's not going to swell outward because the thoracic cage is a cage. So where does the swelling go? Inward, because the lungs are soft and squishy. And so the pressure presses on the lungs, and eventually that pressure here becomes so high, it's higher than your ability of your respiratory muscles to counteract it, and you can't get air in because there's too much resistance of air from within your lungs. You can't get the air in. The pressure has to be negative, and it's become positive. And so you can't get the air into your lungs because of that air pocket and the pressure that's developing. Does that explain it? That's what's happening. So the air trapped in the two membranes makes it pretty much impossible to expand your lungs because the pressure working against your lungs is too great for your respiratory muscles to overcome. You have to get rid of the air pocket. Okay, so I hope that these, so here's a classic pneumothorax. I don't know if the volume is going to be loud. I'll try and check it if it is. I tested the sound when coming in here today. Oh, ads. Okay, I guess my volume's off. No, it isn't. Skip ads. No, I don't want the trial. Okay. So they're showing it in a baby. So you're taking air in. So now they're talking about the visceral pleural being damaged. Okay, so that's the membrane covering the lungs itself. Okay, so I'm going to zoom in. And the outer membrane is the parietal pleura. And the inner membrane over the pinkish lungs, you can't see it, but that's the visceral pleura. So they're going to expand so you can see between those two membranes. Here is a cut or a tear in the lungs through the visceral pleura. Now, air from within the lungs escapes. Every time you inhale, air escapes the lungs and goes into the intrapleural space. And eventually that space gets filled with air, and it becomes positive, and it presses inward because that's the only place for the pressure to go, because it can't press against the thoracic cage. So every breath increases the air in the pocket, and then that presses the lung inwards to eventually where it collapses because you can't take the air in. All right, let's see if I can speed this up. But I think you get the idea. All right. Okay, so let's go to, here's another pneumothorax. What the doctors are doing here is they've actually got the lungs that have been removed from them. Obviously, a person died. Maybe they donated their organs to science, but they basically have a set of lungs connected to the trachea, which is still in place, and attached to the trachea, they've got the ambu bag. So they're putting air into the lungs, and wrapped around the lungs, they've got a plastic kitchen garbage bag that's supposed to act like the parietal pleura. All right, so this is kind of cool. And I'm sure we'll have an ad that we'll have to deal with. Oh, no, we don't. Yay. Awesome. So here is the lungs, the trachea, the ambu bag there with the endotracheal tube. Healthy lungs. Every time they push air in, the lungs go, whoo. Push air in. There's the ambu bag. Now they're going to wrap that healthy set of lungs with a plastic bag that acts as the parietal pleura. There's no tear in the lungs or visceral pleura. So every time the lungs inhale or air is forced in, the bag expands. And when the lungs exhale, the bag shrinks with the lungs. It keeps pace with it. No air is filling the space between the lungs and the bag. Now they've got some lungs that have some tears in them. So every time you force air in, air is going to hiss out that tear and fill the bag. And eventually the bag gets filled up with air with tremendous pressure in it. And that's what a pneumothorax is. So every time they push air in, air will leak out that tear, fill the space. So with every breath, the pneumothorax gets worse. And see how the bag's filling up. All right, but that's a pneumothorax. So what do you do with a pneumothorax? You have to get the air out. Has anyone ever seen a pneumothorax reduced? I took part in it with a dog that got hit by a car and had a pneumothorax. The doctor, listened to it. He could tell by tapping the chest, he could hear where the pressure of the air was. He actually took a big syringe, like a 20 or 60 cc syringe, big old needle too, went through the chest wall in between the ribs, got that air pocket, pulled several syringes full of air out and reduced that. And eventually when the lungs can expand again, then the parietal pleura will stick to the thoracic wall and you watch them and make sure it's not forming again. All right, so here's treatment. I hope this video link didn't break. And this is not a good procedure. The dog was sedated, but it's painful. They put a chest tube in you. Okay, we saw this one. If it's going to repeat some stuff, I'll accelerate it. Okay, so there's a little baby pneumothorax. All that air has to come out. So let's see. Okay, you're kind of dragging. Yes, we know gas exchange. So this is decreased oxygen exchange. I'm looking for the procedure. They really draw it out. Placement of a chest tube. Not enjoyable. My brother said it was probably the most painful thing he'd experienced other than the broken ribs themselves. Here we go. Get that air, tap it off, get it out so that the air, when next breaths happen, the lungs can inflate and then press the visceral pleura and parietal pleura together. There we go. All right. So that is so common. If you ever take part in emergency nursing, you will see that. It's common. Okay. So now you know what a collapsed lung is. Now you know how it's treated. All right, so air enters the intrapleural space, raises that pressure. The pressure pushes against the soft, squishy lungs. They collapse. The only way to treat it is to do a chest tube, get that air out, and then the lungs can inflate again, and hopefully that's the fix of it. Now, if you've got diseased lungs, another thing that I didn't show you is diseased lungs can form these little pockets of air on the surface of the lungs. They're called blebs. And when those blebs rupture, air leaks into the intrapleural space. Now, a chest tube can relieve that problem temporarily, but diseased lungs that form those blebs, your lungs might be damaged to the point where you're looking at a transplant because those blebs are going to continue to form unless you can halt the disease process in its steps. So probably just surface tension, a little vocab, and I'll let you go because I know it's 10:17. Surface tension is the pressure from that thin film of water lining your alveolar sacs. That's what makes them prone to collapse unless surfactant is present. Now, this one right here is important, compliance. When your diaphragm contracts and the thoracic cage expands, the lungs, if the membranes are nice and healthy and flexible, will expand as well, increasing their volume and then changing the air pressure. That is important. And then when you exhale, the lungs bounce back to their normal shape. That's called recoil. I like recoil, not elasticity. So I want you to leave with this image in your mind today. Breathing and exhaling, inhaling, exhaling. This, inhale, compliance. Exhale, recoil. Inhale, compliance. Exhale, recoil. That's all it is. Compliance, recoil. Compliance, recoil. So on Wednesday, when I get into some disorders, I'm going to talk about disorders of compliance and recoil. All right, I'll see some of you in lab today for the P-Lab. You'll make it through. You'll be fine.